ado, if you have any questions, pop them into the chat and we'll get started, and I'll be sending feedback links at the very end. But yeah, take it away.
Yep, thank you very much for the introduction. Any questions about RESP content or about CBBs or whatever you want to ask, throw in the chat box. I'll answer all of it together at the end, just so we get through this in a relatively good time. So let's begin. If you guys can, I've kind of broken this down into sections that you can keep your attention span on, relatively well, because I know how long lectures can drag sometimes. So I'm going to spend the first 20 minutes talking about anatomy and physiology. I'm going to focus mainly on the exam relevant stuff, because I could do a whole lecture series just on the anatomy, but we're going to focus on the relevant things. And we're going to go over some common conditions, which you can see listed here. And then we're going to do some cases at the end. Now, because I'm not sure, what the general level of the whole audience is, I've started the questions with stuff you might be asked in first year, and then as the cases progress, it goes more to second year questions, and the last few cases are kind of what you'd expect from someone just starting third year. So let's start. So we're going to talk over the anatomy. And I will start off by talking about embryology, just because it's the logical place to begin. So the respiratory system develops like a tree. You can see this through this image. In the 4th week, you get these 2 tracheal buds, and they come off like 2 branches. And the 2 branches branch off again, and those branches branch again, and the branches keep getting smaller and smaller, and that keeps happening just like a tree until you get the final, the fetal lungs. And then the very end, just like leaves on a tree, that's where your gas exchange is happening. So then looking at the respiratory anatomy as a whole, starting off with the place where the air enters, everyone knows this, goes in through the nose. And here you've got your additional immune function as well. So you've got the nasal hairs, and you've got the mucus defense. So that kind of gets rid of some of the particles in the air, traps some of the bacteria. And then the air moves to the sinuses. Now, obviously, it only goes in the sinuses if you breathe in through your nose. But so it goes into the sinuses, the function of the sinuses being, and the sinuses are these almost holes in the bones. They're these hollow segments. They're lined with cilia. They're nice and warm. And what they do is they warm the outside air. They make it moist, so it's optimal air condition to breathe into your lungs. And then the air moves down to the larynx, where the epiglottis and your thyroid cartilage is. Think of the epiglottis as the gatekeeper between the trachea and the esophagus, strictly maintaining only air going into the trachea. Obviously, sometimes that doesn't happen, and that's where we get choking. So then we move down the trachea, and we get this bifurcation point. So until now, everything is central, but now we get a bifurcation. So we get this trachea splits into the 2 primary bronchi, so the left and the right. You can see on this image quite clearly that the right one is much steeper, and that becomes important. We'll talk about that in a couple of minutes, why that's important, but just keep that at the back of your mind. And on the bottom here, you've got the diaphragm, which is the main inspiratory powerhouse muscle. So that's driving, your in-breaths. So then once the air has got into the lungs, and you've got all of these divisions and subdivisions of all the bronchi, and you get down to the terminal bronchioles, the respiratory bronchioles, you make it to the alveoli, which I've marked with all of these red dots. And that's where your gas exchange happens. So every time you're taking breath in or out, every time there's air in those alveoli, you've got the gas exchange, which I've shown with these pulsations. So that corresponds to the stuff up here. So you've got these alveolar sacs, completely covered with capillaries. We're going to go over the process of gas exchange as well. We'll revise that. So that's a kind of overview from nose all the way to the alveoli. And we can split that up into the conducting and the respiratory portion of the respiratory system. So the conducting portion, the whole function of the conducting portion is just to get air from outside to the alveoli. So like we talked about, nasal cavity, pharynx, larynx, goes down the trachea and all the different bifurcations until it reaches the terminal bronchioles. No gas exchange is happening anywhere here. It's all of this is just travel for the air to get to where it needs to go, which is this place over here. So we call that anatomical dead space. Called dead space because there's no respiration happening. Where the respiration does start to happen is when we reach the respiratory bronchioles. So respiratory bronchioles is a little bit of respiration, but the majority of respiration happening in the alveolar ducts and the alveoli themselves. So these three portions of the respiratory anatomy are called the respiratory portion because that's where respiration happens. So this is all travel, dead space. This is the actual respiratory portion. And this is just a cartilaginous framework of what I was talking about. So you've got your trachea and you've got the two divisions, and then they divide again, and then they divide into smaller and smaller bronchi, bronchioles. And then as you get to the end, you get your respiratory bronchioles, and then you get your alveoli at the very end of that. So what I was speaking about a minute ago with the right, so this is the first clinical point now, and it's just a little side note, but it's important to remember. So with the right bronchus being a lot steeper than the left, you can see how if you watch that top left corner, if someone accidentally asphyxiates a peanut or some other small object, probability dictates it's much more likely to end up in the right side. So more often than not, if a child is choking or something, if they've aspirated something, it's probably gone into the right lung because that right bronchus is much steeper. So let's break the anatomy down into bones, muscles, nerves, etc. To start with the bones, you've got your sternum in the middle, and then you've got your ribs. Your ribs aren't directly articulating with the sternum itself, they're articulating with the costal cartilage. So you've got these cartilage pieces here, which is like the intermediate. And then the ribs go all the way around the back and they articulate with the vertebrae. And they articulate with the vertebrae through these demifacets. So the cartilage lined little indentations which allow for smooth movement. Now, so all of this isn't a static connected piece. There's a lot of fluidity in the movement, and you can see if you direct your attention over here, why that fluidity is needed. Because every time you breathe in, your bones have to move this much. So if your ribs were fixed all the way around, you wouldn't get any of this bucket handle movement. Called bucket handle. If you have a bucket and the handle on the top, the one that swivels, if you swivel it from one side to the other, it kind of mimics the way that the ribs move. So to allow for this fluidity, that's why you've got the cartilage pieces. Okay. And then lungs have lobes. So the right lung has 3, left lung has 2. This is what it looks like. This is similar to what it looks like in real life. It's sometimes hard to pick out the fissure lines. So these are the fissures. This is the oblique fissure here in the left lung. The left lung only has an oblique fissure. The right lung has an oblique fissure and it has a horizontal one as well. So the right lung has 3 lobes. But this diagram is just to make a bit more sense. So now going on to the muscles. The whole function of the muscles around the rib cage is to facilitate ventilation. Normally at rest, I mean, hopefully all of you are at rest, sitting down watching this lecture, not out of breath. And in that case, when we're just resting and we don't have a high oxygen demand, we use our principal muscles of respiration. Now, we can split that into muscles of inspiration and muscles of expiration. Now, principal muscles of expiration is a bit of a misleading term because if you take a deep breath in, you're using the diaphragm. Most of the power comes from the diaphragm. The diaphragm contracts, expands the lung volume, draws air in. And you also use the interchondral part of your intercostal muscles and your external intercostals as well. The main power comes from the diaphragm. and you're using that to draw breath in. But then for the out breath, you're not really using any muscles, you're just relaxing. And the elastic recoil, which is something we'll revisit. So if you imagine you breathe in, you're stretching everything, you've expanded it, and then you relax your muscles, you have all of that stored up elastic force. It's going to contract back, and that force is enough to just expel the air out at rest. Now, sometimes we need more air than this system can provide, which is where our accessory muscles come in. So the accessory muscles are muscles we can use to breathe when we need to increase the speed at which we're breathing, increase the volume of air we're taking every minute. So the accessory muscles of inspiration are your things like sternocleidomastoid up in the neck, your scalenes also in the neck. You activate all of your principal muscles. And then the main change being on the out breath, instead of having passive recoil, we now force the air out. So the internal intercostals minus the intercondylar part, they contract. All of your abdominal muscles contract, really forcing that intrathoracic pressure really high, forcing the air out quicker so we can take another in-breath. So that's what your accessory muscles of inspiration and expiration are for. And you can see that demonstrated over here. So the up arrows are the inspiration, the down arrows are expiration. So you have all of these muscles and they all do different things. Okay. Now, I just want everyone to take a look at these two. Feel free to put in the chat if you want. I won't be able to look at it, but if anyone wants to have a guess at what muscles are being used in this top one, there's two muscles. You can see these people are both in, using the accessory muscles of respiration. If you guys want to put in the chat, or if you just want to have a think to yourselves, what muscles are being used here and what muscles are being used here, I'll come back to it later. So going to vasculature, the photo on the left is just a general overview of the way that the arterial system is laid out intrathoracically. So you've got this big abdominal and thoracic aorta up here. You've got all the intercostal arteries, and we can zoom in on those intercostal arteries here. Important bit of anatomy, because underneath each rib, so each rib has a groove. This is a cross section of a rib. Under the groove of each rib, you have this neurovascular bundle consisting of the intercostal vein, artery, and nerve. And they're easy to remember what they do because they're called intercostal vein, artery, and nerve. They supply the intercostal muscles with blood and nervous input. And then the third bit of important vasculature to revisit is the cardiopulmonary circulation. So I'm sure you guys have seen this if you've done A-level biology or even physiology last year. But to sum it up quickly, deoxygenated blood comes back from the body, enters the right side of the heart, and then goes into the right atrium, right ventricle. Right ventricle shoots it out through the pulmonary veins, sorry, the pulmonary arteries. So the only arteries which carry deoxygenated blood. So the pulmonary arteries take that deoxygenated blood to the lungs, where they're then oxygenated and sent back to the left side of the heart, this time through the pulmonary veins. So the veins are carrying the oxygenated blood, and then that goes into the left ventricle and is fired out to the rest of the body. So that's an important bit of vasculature to revisit. And a side note, the lungs aren't supplied by the pulmonary arteries or the veins. They're supplied by something called the bronchial artery. Bronchial artery has loads of different branches, and that supplies the majority of the lungs themselves, the lung tissue, with the blood that it needs to function. Going on to nerves. And remember, there's much more that we can talk about with this. This is just kind of the main exam relevant stuff, and there will be exam relevant stuff in here which I haven't covered for time's sake, but this is kind of the bare minimum, the bare bones. So in terms of nerves, your phrenic nerve supplies the diaphragm. So diaphragm contractions are induced by the phrenic nerve. C345 keeps the diaphragm alive, is one of the medical mnemonic favorites. So that's just saying that the spinal roots of the phrenic nerve are C3, C4, and C5. They combine to make the phrenic nerve, and they power the diaphragm. The intercostal nerve supply the intercostal muscles, as we've talked about. And then feedback, so sensory sensory signals going back from the lungs, from all the stretch receptors back up to respiratory center or through the reflex arcs. They're taken through the parasympathetic fibers in the vagus nerve. And then for all of the other things like mucus production, vascular permeability, blood flow, you've got a amalgamation of autonomic nervous fibers, which are referred to as the pulmonary plexus. The pulmonary plexus is just loads of different nervous outflows which combine to form a plexus, and that controls all of these other little things that you can see in this box over here. And talking about the control of ventilation itself, so how do we know, or how does our brain know how much to breathe? How does it know to breathe quicker when we're exercising and breathe slower when we're sleeping? So we have things called chemoreceptors, and they detect. So we have different types of chemoreceptors. Central, which only can detect CO2, and they live in the brain extracellular fluid. So they live on the brain side of the blood-brain barrier, and they're sensing how much CO2 is in the extracellular fluid. And if the CO2 goes too high, you need to breathe quicker to exhale and get rid of that CO2. So it tells the respiratory centers to increase the rate of ventilation. And you also have peripheral chemoreceptors, which you find in the aortic arch and the carotid bifurcation. Now, these do the same thing. They look at the carbon dioxide, but they also look at oxygen levels in the arterial blood. And for any reason, if O2 goes too low or CO2 goes too high, they signal to the brain, and the brain goes, okay, we need to breathe faster, and it sends signals back down that network, and your rate of ventilation increases. So pleural space, it's a potential space. Normally, physiologically, it shouldn't exist. What the pleural space is you have, also known as pleural cavity, same thing, but you have two layers of pleura. So the innermost layer attached to the lungs is called the visceral pleura, and then you have a little bit of fluid, which is secreted by the epithelial cells lining the pleura. You have a little bit of fluid in between, and then external to that, you have the parietal pleura. So visceral pleura, pleural fluid, which is, it's not masses of fluid, it's a tiny bit of fluid. And then you have the parietal pleura. And the surface tension from that little bit of pleural fluid is what helps these stick together. Now, when you breathe in, the muscles tug on the parietal pleura, which tugs on the fluid, which tugs on the visceral pleura, which tugs on the lungs. This system is what enables your muscles to pull the lungs open to reduce the pressure inside and draw air in. Now, it's key, just keep in your mind that it's a potential space. So normally there's very little in that space, but because it's a potential space, it can become filled with things. And that's when we start getting medical problems. And we're going to talk about some of those conditions in a bit. So that's it. Done with anatomy. We're going to take a quick, 10-15 second break just to refresh. If anatomy is something you find really challenging and you need to revisit it, don't worry. We're going to start physiology now, which is something separate. So we're done with anatomy. And we're going to talk about respiratory physiology now. So reset, and let's begin again. We'll start with ventilation mechanics, the physiology of how we actually breathe. And this top diagram is with all the pressures, and I've just simplified that with this little thing which I've made in the bottom right corner is just a simplified version of this. So I want all of you, if I don't know if you're going to do it or not, but if you want to, just take a deep breath in and then completely relax and just let the breath leave, and you'll find that the breath will keep leaving until a certain point, and then it will just stop and no breath will go in, no breath will go out. So that point which you've reached is where the elastic recoil of all the muscles and elastic fibers is perfectly balanced with the resting muscle tone of the chest wall muscles. Now, elastic recoil, because when you contract and you stretch everything. You expand the chest, all the lung tissue stretches, all the muscles contract. You've got a lot of stored potential energy. So when you relax, it's like letting an elastic band go. all of that recoil energy goes back and the chest falls and the volume becomes smaller. To that point when no air is going in or out, that's when the recoil forces are balanced with the muscle tone. Now, if we want air to go in, the muscles need to be stronger than the recoil. So the muscles, the inspiratory muscles, which we talked about, consume ATP. They expand, they pull on the pleural cavity, which pulls on the lungs, and they expand the lung volume. Now, if you expand an object, if you expand a hollow object, the pressure inside drops. So that's physics. And then because you have lower pressure inside than you have outside, the air is going to rush to the zone of lower pressure, which is inside your lungs. So when your chest wall expands, creates lower pressure, the air is drawn into your lungs, and then it goes for gas exchange. Now, when we want to get the air out, we want the intrathoracic pressure to be higher than the pressure outside. So the expiratory muscles contract if we're using them actively, or just the amount of stored potential elastic energy is enough to increase the pressure inside compared to outside. And because there's higher pressure inside, the air is forced out. And you do that loads and loads of times a minute, and suddenly you're breathing. So that's ventilation mechanics simplified. It's all this balance between muscle contraction and recoil. And then the recoil can be assisted by the expiratory muscle contraction. Okay. If you guys have any questions as we go along, just throw them in the chat. I won't respond to them now, but we'll cover at the end, just so you don't forget your questions. So now covering physiology of gas exchange happens in the respiratory zones, like we talked about before, those last three bits in the lung anatomy. And when you get down to the very end, essentially all you have is, this is zoomed in on one alveolar sac. So you have all these alveoli, these grape-like structures, and there's loads of small ones to increase the surface area for gas exchange. And when you zoom in on just one of these, this is what it looks like. So you have a really tiny arteriole turning into a capillary. You have loads of deoxygenated blood here. And so you have loads of CO2 in the blood, very little CO2 in the air, which is over here in the alveoli. So all the CO2 moves from the blood into the alveolar space because it's just diffusion mechanics. And then as this blood goes through, it's got very little oxygen in it compared to the fresh air which has been inspired into the alveolar sac. So the oxygen moves from here into the capillary because, again, diffusion. And so the blood comes in deoxygenated, full of waste products and carbon dioxide, and it leaves, as fresh arterial blood because the oxygen has now been replenished, carbon dioxide is being removed. It's ready to go back to the heart to be pumped to the rest of the body. This is waste blood from the body getting freshened up, and then it's going out back to the heart to be resupplied to the body. Now, a side note is you have these really small structures, and they would be very difficult to inflate, and they collapse into each other. It's not probably, they do collapse into each other if you don't have this thing called surfactant. Now, what surfactant does is it stops smaller alveoli from collapsing into bigger ones, and it lets bigger ones, inflate easier. So it keeps the balance between different sized alveoli, because not all alveoli are the same size. And you can see that summarized here. Without surfactant, when the air comes in, it would just go straight into here, and this alveoli would probably collapse into this one. But with surfactant, it makes them the same difficulty or the same easiness to inflate by the incoming air, which means air is evenly distributed. And a clinical relevance point of that is when we have premature babies, I'm saying that, very, very premature, they haven't had a chance the type 2 pneumocyte cells haven't produced surfactant yet. So when they're born, if we don't do interventions before they're born, they can't breathe because all the alveoli collapse and they go into something called respiratory distress syndrome. So what we do to preempt that is we give, before delivery of the premature baby, we can give corticosteroids, which basically ramps these type 2 pneumocytes up and forces them to produce surfactant early. And then when the premature baby is born, there's a much reduced chance that they'll have respiratory distress syndrome because they have the surfactant. Okay. Another concept in respiratory physiology to be aware of is radial traction. Now, when you have these tiny bronchioles at the end and you have masses of intrathoracic pressure squeezing from outside, it's reasonable to expect that they just collapse because they're so small. How are they going to resist all of that pressure? And the way they resist that pressure is through radial traction. So if you think of the tube of the bronchiole and you think of loads of little elastic fibers coming off it, and they pull the bronchiole open. So the elastic forces of the alveoli and surrounding fibers keeping the bronchiole open, that collectively is just known as, that's what radial traction is. It's important to know about it because loss of radial traction is a prominent feature in one of the conditions we're going to talk about later. And VQ ratio, this is really a whole lecture's worth. This one concept there is a whole lecture in itself. But you have in the lungs, if you really boil things down, you've got ventilation and perfusion. So ventilation being the air which comes in and out, perfusion being the blood flow which is coming and releasing its carbon dioxide and taking the oxygen. And this is zoomed in on the alveolar gas exchange which we saw before. So you have perfusion, here the red blood cells, and you have ventilation. The rate of ventilation divided by the rate of perfusion is the VQ ratio. Right. Normally, at rest, like all of you guys are now, 4 liters of air comes in and out per minute, and 5 liters of blood circulates around per minute. So you do 4 divided by 5, the per minutes cancel out, and 4 over 5, 0.8 is a normal healthy VQ ratio at rest. And we can expect when we start to exercise, because we need more air, we're breathing faster, the air intake per minute goes closer to 5 liters a minute, and our VQ ratio then becomes 5 liters of air per minute divided by still 5 liters of blood. So the VQ ratio goes more towards 1, which is still physiologically normal, if you're exercising. The reason this is important is if you have medical problems that disrupt your gas exchange, what your lungs do is they go, okay, we need to try and maintain this ratio of 0.8 as best we can so that we're still getting enough oxygen. So what they do is they divert the blood to the best perfused alveoli. Right now, you're going to be getting equal amounts of blood to all your alveoli because they're all healthy. When someone with areas of damage, the lung is going to make itself more efficient and send the blood to the well-perfused alveoli. What happens then is you're going to have changes to the VQ ratio. So you're going to have changes to the perfusion or changes to the ventilation, and that number is not going to be 0.8 anymore. So if I have a medical problem where, a lot of my alveoli are damaged, I'm going to have really poor ventilation because the air physically can't get to the gas exchange point. So ventilation is reduced, even though perfusion is still fine. So if we go into fractions, it's going to be, instead of 4 over 5, it's going to be a much smaller number divided by 5. And that's going to make the VQ ratio smaller. So if someone has a much lower VQ ratio than normal, we know that it's a ventilation problem because this top number is lower. If we go the other way around, let's say someone has perfect ventilation, but they've had a problem with their perfusion, which is a very important medical condition we're going to talk about in a bit. So let's say the blood flow has been severely impaired. You've now got 4 divided by a much smaller number than 5. So your VQ ratio is going to be much higher than 1, and that's pathological. So we know there's a problem with the perfusion. We can do a VQ scan. The scan measures the rate of ventilation, measures the rate of perfusion, divides them and gives you a number. That number can just aid your clinical diagnosis. So if someone's got a really high VQ ratio, and you think that they have a problem with the perfusion, it kind of fits the picture. So that's VQ ratio summed up. But like I said, that could be a whole lecture in itself. So that's it. Pathology. is pathology, isn't it? So we've done physiology, we've done anatomy. Take another 10-15 second breather, and then we'll crack on with airway disease. In airway disease, we're going to speak about asthma and COPD. So we'll start with asthma. And before we do that, like I said, I don't know what level all of you guys are at because you're coming from different unis. I don't know when you do respiratory, but I'm just going to quickly talk about these three things because it's important to know what they are for the upcoming conditions. So we'll start with this one. There's obviously chest x-ray. This is what a normal chest x-ray looks like. Just have a mental note of you've got this nice curve of the diaphragm here. I'm just talking you through the main important things to remember. So you've got this nice curved raised diaphragm. You've got this cardiac shadow. This is the heart here. The trachea here is nice and center in the middle. And then just have a mental note of the haziness of these lung fields. So this is normal. This is the normal air conduction. So this is what it normally looks like. Just have a mental note of this color. And now this thing over here is called spirometry. So it lets us measure how forcefully someone can expire all the air from their lungs. This curve up here, nice and steep, means they're expiring really fast. They can get that air out really quickly, nice and healthy. This is normal spirometry line. If someone has an obstructive lung disease, which we're going to talk about what that is, you might expect to find this pattern. Again, just keep these things in your mind. It's fine if you don't understand the reasons why. But if it's obstructive, it will be more like this. If it's restrictive, you're restricting the amount of air they can expire. So that line isn't going to reach the top. It's just going to plateau down here. And these are flow volume loops. Again, visual representation of different types of lung pathology. So we can see this is normal. Obstructive, it's harder to get the air out because it's being obstructed. Therefore, the curve takes much more time to get back to the bottom. So it takes longer because it's obstructed. And then when you inspire again, it takes way longer because of the obstruction. And then restrictive ones will look like this. It's like someone's squashed the normal one. And it makes sense because it's restrictive. You can't breathe in or out as much. So your flow volume is restricted. So that's why you get this kind of shape. And then I don't have time to explain arterial blood gases today, but this is what that is. So we can take a sample of arterial blood, usually from the radial artery. We put it in a machine and it gives us these values. pH, we want to be in this range. If it's below or above, we know there's a problem. Tells us carbon dioxide, so we can see if someone's got too high CO2, if they've got too low if they've got too low oxygen. Bicarb as well. So if you've done ABGs, that's fine. But if you haven't, then just look over it. You look over it whenever you cover it in lectures, but unfortunately, I don't have time to cover it today. Let's start off with asthma. Type 1 hypersensitivity reaction. It's a chronic airway disease characterized by inflammation, immune inflammation, because of various triggers. You know, what happens is you become sensitized to these things like cigarette smoke or mold, dust mites, pet dander, various infections. Pollen's a common one. And what happens when you come in contact with these? And I know it's not, you can't become sensitized to cold air, but you know, cold air, the mechanism's a bit, the trigger mechanism is different. But whatever trigger you have, it leads to an immune reaction. So, and it's an increased immune reaction, much more than you would expect. What happens is you get all of your immune mediators released, like your histamines and all your chemicals that recruit T cells and mast cells and all of that stuff. And so you get this massive immune response, which causes inflammation. And if you have a tiny little airway and you have inflammation in it, it's going to become narrowed. And if you narrow the airway, you can't get as much air through there. So you become breathless. And the main thing is you get the goblet cells producing more mucus, And then smooth muscle hypertrophy. Over time, you get smooth muscle hypertrophy, which only further serves to narrow those airways. The untreated prolonged asthma will just get worse and worse and worse because those airways are narrowing every time even more and more, restricting the amount of air that can come in. Remember the VQ ratio as we talked about. Perfusion's fine, but ventilation's reduced. So we have a lower VQ ratio in asthma. The important distinction to make between asthma and a lot of other so this is an obstructive lung pathology because we're obstructing the flow of air because we're narrowing all of those airways. Asthma is reversible. If you give them medication, they're right back to normal. You know, some people, it might take more medication than others, but they're going to get back to normal. That's the distinction. Asthma is reversible. Intermittent symptoms, they come and go depending on the triggers, but it is a reversible condition. You can see here, there's a nice open, healthy airway, big lumen. Then with loads of asthma attacks, you get all of this hypertrophy of the muscles. The epithelial lining becomes all convoluted, loads of mucus production. And then what happens is in the middle, you have just a much smaller space for air to flow. And because of that, so even when you get to clinical years, still keep on top of your physiology because it will just help you understand why different medical problems present as they do. So because my airways are because asthmatic patients' airways are narrowed, they get a cough and they become wheezy because if you pass air through a narrow space, it's more likely to make a sound. So passing air through a narrowed airway makes it wheezy. So you get this wheezing, asthmatic wheeze. And because you can't get enough oxygen into your body because your airways are narrowed, you become breathless because your body is trying to breathe faster. So remember those chemoreceptors are sending signals to breathe faster, get more oxygen in. So you become breathless. And then because everything is contracted, you get a tight chest. And because you have less oxygen and because you can't shift air in and out as quick, your body starts to breathe faster, which is tachypnea. And then your heart beats quicker, which is tachycardia, to get the oxygen, to get the reduced amount of oxygen in the blood. It's still trying to get that to the organs. So because there's less oxygen availability, your heart beats faster to try and get the existing amount of oxygen away to the peripheries. And then you leave it long enough during an asthma attack, they're going to start having low saturations because they're not getting enough air and the blood oxygen level is just going to keep falling. Eczema I put in here because historically asthma is part of something called the atopic triad, which is consisting of asthma, hay fever, and eczema. So you might see if someone has asthma, it's not uncommon for them to have eczema rashes as well. But that's just because of the underlying pathophysiology of it being an immune reaction rather than the eczema and asthma being, directly linked. How we're going to investigate for it? We can do peak flow measurements, which will be reduced. Peak flow just measures your air output, and then spirometry again. The graphs that we looked at before, you're going to see the obstructive pattern with reversibility. So what that means is this is what it's going to look like when they have asthma symptoms. It's slower because it's obstruction. It's taking longer for it to reach the peak. But then as soon as we give them bronchodilators, so your salbutamol, your inhalers, they go right back to normal. And that's diagnostic because you have that obstructive pattern with reversibility. Now the reversibility, the improvement has to be greater than 12% in FEV1. So you have to have a reversibility of more than 12% FEV1, and then it's asthma. If it's like 11% or something, it still can be asthma, but generally it's more than 12%. And you have this other thing called FeNO. This is more for clinical years, but to summarize it, we test how much nitric oxide someone is exhaling. In asthmatic patients, it will be elevated. That's it. I've put this little video in here that you guys can listen to, and it just shows the sounds of asthma. But if you want to find it before the slides come out, just search in sounds of asthma and you'll hear that typical asthmatic wheeze. Okay. How we manage it? Obviously, get rid of the trigger. If there's a pet which keeps triggering the asthma, then you're gonna have to take measures to make sure that the patient is not so exposed. So making sure they're in separate rooms, or only interacting with the pet kind of outdoors, things like that. Obviously, you can't get rid of the pet, but there are some species of pets, interestingly enough, some dog species which are specifically hypoallergenic, so their coats are less likely to trigger asthma. So that's just a side note. And then you can use the BTS asthma algorithm. So it's just a stepwise treatment plan, and it starts with your salbutamol reliever inhaler, and then you can add on corticosteroids. Now, steroids just dampen the immune response. So they're your preventer inhaler, making it less likely that someone's going to have an exacerbation. And this is your bread and butter of asthma management, the very start. But remember, the brown one is the steroid, the preventer. You're meant to take that every day, but most asthma patients don't. So then they start having symptoms and they use the salbutamol one, which is an instant fix. But sometimes, and then, if that doesn't work and it's not managing, we can add further medications, but that's something you'll learn in clinical years. And then a quick overview of how salbutamol actually works. So binds to the beta-2 adrenoceptors, you get increased cyclic AMP levels, which then you get this whole this calcium pathway and the phosphorylation, and that eventually just leads to relaxation of the smooth muscles. So you're giving that salbutamol in an acute asthma attack because the muscles are really tight and contracted. It goes and binds to the beta-2 receptors as an agonist, and then you have the whole cell pathway, and the end result that is smooth muscle relaxation. So that's why they take the salbutamol, and almost immediately in most cases they're relieved of their symptoms because the muscles have dilated. But sometimes that doesn't happen. When you get the exacerbation, also known as asthma attack, sometimes the salbutamol inhaler is not enough, or maybe they don't have the salbutamol inhaler on hand. And this is where you get that prolonged severe untreated asthma. And if you don't manage it, your airways are going to keep narrowing. You're going to have less and less oxygen in your blood, higher and higher carbon dioxide, and that eventually leads to respiratory failure and death. And we can class the severity here. Again, this is something you're going to mainly cover in clinical years, but I've put this here for you to refer to afterwards. And it's just the different kind of symptoms, how we classify someone's asthma severity, and then we can manage it. So you can see how if someone has low oxygen, we give them oxygen, and then we always start with the salbutamol, nebulized salbutamol. If that doesn't work, we give them steroids. So this is all if the salbutamol failed. And then if the steroid fails, then we go up to these more powerful medications. I'm not going to cover these because this is a little bit beyond preclinical, but we have these medications that we can rely upon, and they all just work to dilate airways, relax muscles through different pathways. So they don't bind to, these ones don't bind to beta-2 receptors. That's what salbutamol does. These work in a different way. So talk about COPD next. COPD is different from asthma in the sense that it is not intermittent, it's continuous. So this person is not breathless one day and then they're fine the next day. It's all the time, and it gets worse slowly over time. And it's not reversible. So if you do this salbutamol reversibility test, the symptoms aren't going to resolve because the pathophysiology is different. Now, the most common cause of COPD is smoking, but you can get COPD from other things like industrial exposure to chemicals over a long period of time, genetic conditions like alpha-1 antitrypsin deficiency. And the pathophysiology is broken down into two conditions. So you can get either one of these conditions. You can just have emphysema or chronic bronchitis, but when they combine, that's when you get COPD. Chronic bronchitis is defined as a productive cough with 3 months out of the year for more than 2 years consistently. And what happens is you get your exposure. So if you take cigarette smoke, so you get all your nasty chemicals in cigarette smoke. That triggers an inflammatory response, more goblet cells. So you can see how this is a little bit similar to asthma. And you get mucus hypersecretion. but also the toxins impair the mucociliary clearance mechanisms. So you get loads more mucus than normal and you can't clear it. So it just accumulates. Then you get loads of edema in your small, tiny airways, and they get irritated and the cycle continues. More inflammation, more mucus, more no clearance of it, more edema, more irritation, repeat, repeat, repeat. And over months and months and months, this leads to loads of fibrosis, destruction of the bronchial architecture, and they become really narrowed. You can see how narrowed this lumen is. How are you going to get enough air through those when they're so narrowed and inflamed and full of mucus? And then on top of that, you also have the emphysema picture. So you get those toxins, and they lead to destruction of the elastic framework around the alveoli and the bronchioles. Remember radial traction that we talked about before, where the elastic fibers are pulling everything open. So they get destroyed by the emphysema process. And then because you don't have radial traction, lots of small alveoli get lost. So you have less subseraphic gas exchange, and then your bronchioles collapse. And they collapse and they trap air inside them. Keep that in mind, they trap air in them. So you've got these narrowed airways full of mucus and less subseraphic gas exchange, and they're collapsed. And so you can see how it's really just gonna, over a long time, destroy your ability to breathe properly, which is gonna explain a lot of the symptoms that we're gonna talk about. Now, the reason smoking does this is because the chemicals do these processes, they contribute directly to them, and cigarette smoke inhibits alpha-1 antitrypsin, which is an enzyme. And you have the same problem in alpha-1 antitrypsin deficiency, you don't have the enzyme. Now, what alpha-1 antitrypsin does, it's like a gatekeeper against the enzyme elastase. So elastase wants to come and destroy all of the elastic frameworks because it's elastase, it will eat all of the elastic fibers. But A1 antitrypsin comes and it stands in the way, and it's like a guardian against that. So it controls the elastase activity. So you can see if we inhibit the antitrypsin, or if we don't have it because of the deficiency, elastase is going to act unchecked and destroy all of the elastic framework, which is why emphysema happens. Okay, COPD pathophysiology is important to get a good understanding of. Now, because of our narrowed airways, we get this productive cough, loads of sputum. We can't get enough oxygen into the blood, so reduced exercise tolerance. Again, narrowed airways, passing air through a smaller lumen causes a wheeze. And then because we have loads of mucus just sitting there festering with bacteria, we get frequent respiratory infections. Reduced oxygen availability, tachypnea and tachycardia for the same reasons I explained before. And because we're so out of breath, you start to use your accessory muscles. So one of the patients from the two videos which I had of accessory muscle usage, one of them was COPD, and they lean forward to try and get more oxygen and relieve some of that pressure. Remember those bronchioles collapsing and they trap air inside them. So that's why you get barrel chest, because you've got chronically trapped air and you're constantly breathing in more, and that chronic trapped air over a long time expands your chest, and you become this guy. This guy hasn't gone to the gym and got a massive chest. This is from air trapping, and his chest is literally expanded. And then because you have chronic hypoxia, you have an overloaded cardiac circuit because you've got this tachycardia constantly. You've got the vasoconstriction, the arterial constriction to try and get blood to the peripheries quicker. And over a long time, this overloads the heart and stretches the right ventricle. And you can, because in what actually happens is in the pulmonary, so the pulmonary vasculature, which directs blood towards gas exchange, it narrows so that the blood can spend more time getting oxygen, because this person with COPD can't breathe as quick and as efficiently as a healthy person. So all of that vasculature constricts, increasing the pressure so that the blood has more time to gain oxygen from gas exchange. All of that pressure backs right up into the right atrium and ventricle where this blood is coming from, and that dilates the right side of the heart, causing right-sided heart failure, which can then progress to congestive heart failure. So that's the pathophysiology of how you get heart failure and COPD. And then again, another video that you can watch in your own time of the actual barrel chest. Investigations that we do, we can look at full blood count, because if you have less oxygen chronically, the natural response of the body is to make more red blood cells. So you have an increased oxygen capacity or increased oxygen carrying capacity, which is polycythemia. You do pulse ox, you might find, oh, this person's, sitting relatively happily with oxygen saturations of 92, 93%. Whereas if we had sats of 92, we'd be quite out of breath. But what's happened is this person's been hypoxic for so long that their body's just become used to it, and that is the new normal, which is why the chemoreceptors are so adjusted to that reduced level of oxygen that they don't trigger that quick breathing. It's normal for this person. They're so adapted to it, which is why we get respiratory acidosis, because we have chronically high levels of carbon dioxide. Again, if you haven't done ABGs, just completely ignore this, but you have chronically high CO2 because we can't get rid of it. And then the chemoreceptors just become used to it. And so then you get a compensatory mechanism with the increased bicarb. And then this person just lives very, looks relatively normal when they actually have really low O2 sats and elevated CO2 that would make us really breathless because they've adapted to it. You don't get that same response. Spirometry, you get obstructive pattern again because you're obstructing the air outflow. Obstructive pattern, obstruction of airflow. But this time you don't get reversibility. If you give them salbutamol inhalers, you might get a 2 or 3% improvement, but it's not going to be more than 12% like you have with asthma. It's going to stay relatively obstructed. Chest X-ray. This is a normal chest X-ray. This is why I said keep a mental note of it. So you can see this diaphragm curve. Just watch that and watch how dark these lung fields are. This is a COPD X-ray next. You can see darker lung fields, flatter diaphragm, much bigger rib cage because of that chronic air trapping. That is the barrel chest that you're seeing. You're seeing a barrel chest X-ray. That chest has become so chronically hyperinflated, it's physically bigger. You can see it on the X-ray. You can see normal X-ray, barrel chest, normal X-ray, barrel chest. You can even see some subtle signs of right heart failure beginning to ensue here. And we can look at the signs of heart failure by doing an echo scan. So there's just an ultrasound scan of the heart to look for, thickened right ventricle, dilated right ventricle, etc. How we manage it, obviously, number one is if they're smoking 40 cigarettes a day, stop smoking, because otherwise no treatments are going to really help them. The COPD is just going to get worse every single day if they keep smoking. Vaccinate them against, because they're high risk for getting respiratory infections, so we're giving them pneumococcal vaccinations. And then we can also improve their respiratory health by getting them to do exercise rehabilitation. And we can try and open up the airways a little bit, but the mainstay of COPD management is stopping smoking and exercise rehab. But we can give these for kind of symptomatic relief. And influenza vaccinations as well. So to basically reduce their infection risk. So now we're going to move on to the interstitial space. Remember that potential space that we talked about. This is what can happen when air gets into that potential space. So that space can be filled with pus, it can get filled with blood. If it gets filled with pus, empyema. If it gets filled with blood, it's called hemothorax. If it gets filled with air, which is what we're going to talk about, it's called a pneumothorax. Now, remember, normally the layers are sealed up, but if I find a way to introduce a gap in there, the easiest thing to imagine is trauma. So, if you're in a road traffic accident and you get a perforation to the chest wall and it goes into the pleural cavity and into the lung, suddenly those layers get split apart and there's a path for air to enter that space. So normally it's closed off everywhere, but now suddenly the air can enter through there. And because you no longer have the seal, if you imagine a balloon, if you hold an inflated balloon like this with your hand, and your hand is the pleural pleural membrane and you let go of the balloon's going to shrink and your hand will still be there. But the balloon's not in your hand anymore. So that's the same thing. So that the lung has shrunk, but the pleural membrane's still there. And you get all of this extra space in between my two hands is where that air accumulates. So that's the pneumothorax. Any interruption to that seal is going to cause pneumothorax. So connective tissue disorders, that weak connective tissue prone to rupture. If you have COPD, because that chronic cough, the weakened elastic fibers make it more prone to rupturing. You can get rupture for no apparent cause. I could go running in the park completely healthy and I could just get a pneumothorax just because of bad luck. But that's less likely to be a severe pneumothorax. And then trauma as well. And when we're doing certain medical procedures like putting in central lines, it can perforate the pleural seal. So, and cancers as well can literally erode into the pleural membrane, or you can get cancers within the pleural cavity, and then suddenly you get all of this air rushing in. And because a lung has collapsed, our patient is now breathless. Obviously, they're breathless because they only have the capacity of one lung. And you've irritated this whole pleural membrane. So you get sudden onset severe pleuritic chest pain. Pleuritic chest pain being worse when you breathe in and out. If they're really small pneumothorax, like 1 centimeter or 1.5 centimeters, the patient might not even have any symptoms. But for the more severe ones, which are induced by things like trauma, they're probably going to be symptomatic. Because one lung is collapsed, you don't have breath sounds on one side. And because there is now loads of air in here, instead of lung and then air, when you percuss it, when you do the chest tapping, it's going to be much more resonant because you don't have that lung tissue to absorb some of the sound. Chest expansion you might only observe it on one side, where the side that the lung is inflated. Now, sometimes when a lot of air accumulates in one side, it can increase the pressure on this side much more than this side. And when we have that, that's called a tension pneumothorax. So you can see here, remember I said before, trachea nice and central in the middle. We get loads of pressure accumulating on this side. That becomes a life-threatening pneumothorax, which needs to be managed immediately. That's a tension. So you can see here the trachea is being pushed to the side. This patient can't breathe now. They can hardly breathe at all because the trachea is being pushed. And you use chest x-ray for that. There's a pneumothorax algorithm. It's got all loads of nuances based on the size of the pneumothorax, past medical history. We're going to skip over that. We're just going to keep it simple. If it's really tiny, we can just observe it and leave it. But if it's bigger, we can put something called a large bore cannula into the second intercostal space. They could ask you this in preclinical exams. So large bore cannula, second intercostal space, put it through the system, and it just lets the air drain out and lets the lung reinflate. That's it. So there's air trapped, well, it's air stuck in that pleural cavity. We stick a needle in there, let all the air come out, let the lung reinflate, and then the pleural seals will go back together and they'll stick, and then the person can now breathe. If someone keeps having loads of pneumothoraces, we can do pleurodesis. So they put a chemical in between the two pleural membranes. Commonly they use, it's a mixture of some chemicals, one of which is talcum powder, like the white baby powder. So that plus a few other chemicals, they put it into the pleural space, and that irritates the pleural membrane so much it causes loads of inflammation, and inflammatory tissue is sticky. So the two pleural membranes become really irritated and inflamed, and they stick together. And because you've made a physical connection, they won't separate again. So you've permanently sealed the pleural cavity. That's what pleurodesis is. So interstitial space done. We're running a little bit late. We're going to go into vascular pathology now. Vascular respiratory stuff. This is what I was alluding to earlier in the lecture, when we have a massively elevated VQ. Pulmonary embolism. Now, what is a pulmonary embolism? One of the highest causes of death due to vascular pathology, one of the highest causes of spontaneous mortality in hospital patients, spontaneous death, is what happens is when you get a clot in the pulmonary arteries, So the arteries that are taking blood from the heart to the lungs, you get a clot in them. It's going to occlude blood flow to the lungs. So suddenly you have normal ventilation, right? You can still breathe in, like the path of air is not impaired, but your perfusion is cut massively. So you have, instead of 4 divided by 5, which gives us 0.8 normally, now let's say you have 4 divided by 2. Your VQ ratio is now 2.0 instead of 0.8, which is massively elevated. So that's why pulmonary embolism caused a raised VQ. Now the causes are the same as DVT and any other cause of hypercoagulability. So most of the PEs, most of the pulmonary embolisms come from a DVT, so a deep venous thrombosis in the cuff, which is dislodged and has traveled all the way up through the circulation. It's come in here through the heart, and then it's gone and lodged into the pulmonary artery. And then other risk factors and causes, anything which screws with Virchow's triad, so surgery, because you've got that immobility, pregnancy, because it's a hypercoagulable state and reduced movement, thrombophilias, malignancy. I've put thrombophilias on there twice, sorry, and bed rest because of that immobility. So any disruption to Virchow's triad is going to predispose someone to a pulmonary embolism. You get that clot blocks off the pulmonary artery or one of the branches of. And because you can't get enough blood to do gas exchange, so this is why pathophys is important, because it helps you understand why the symptoms develop. Because you can't get enough blood to take the oxygen from gas exchange because the blood flow is impaired. Person's oxygen availability reduces, they become short of breath. You have pleuritic chest pain as well, very typical of pulmonary embolism, and they start coughing up blood. That's the typical triad. If you ever see shortness of breath, pleuritic chest pain, and coughing up blood, 9 times out of 10 on an exam, it's going to be pulmonary embolism. And then because of the reduced oxygen availability, again, tachycardia, tachypnea, I hope you can start to see a theme here. A lot of these respiratory conditions are presenting with tachycardia, tachypnea. And then because most DVTs are from, most pulmonary embolisms are from a dislodged DVT, we can look for the signs of a DVT, which is a swollen, red, hot, painful cough. So if we see someone short of breath with a swollen, painful cough, it's going to be a PE. So we can work out the oxygen sats. Wells score is a clinical scoring system, which lets us work out how likely it is that someone's going to have a pulmonary embolism. ECG can show specific changes. Most commonly, it's sinus tachycardia over here, tachycardia, but you can get something called S1, Q3, T3 changes. That's more clinical. We do a chest X-ray to rule out other pathology. Usually can't see a pulmonary embolism. It's very uncommon to be able to see one on a chest X-ray. But we do a chest X-ray to rule out other causes of the patient's presentation. D-dimer is a breakdown product of clots. So if you have a clot, D-dimer is going to be higher. So because pulmonary embolism is basically a massive clot, we expect the D-dimer to be raised. Then we can do CTPA. So VQ scan, you guys already know what that is, and I've already explained why we would do that in this case. You can do a CTPA, which is computerized tomography of the pulmonary arteries. And you can see here, this big, long, gray thing is it's what we call a saddle embolus sitting in the pulmonary artery. So that's a massive blood clot obstructing the blood flow. That's what that big gray thing is. And because someone is hypercoagulable and they've clotted, what we want to do is reduce their coagulability. So we can give heparin, low molecular weight heparin. If it's a massive P, so massive P means if they're hemodynamically unstable. So if someone's got a pulmonary embolism and their blood pressure is tanking below 90/60, or the heart rate's through the roof, and we think they're imminently gonna die because they're that severely unwell, we can give alteplase, which will rapidly eats away at the clot and gets rid of it. But usually we give, for most people, we give a Pixaban, which is a DOAC, same family as rivaroxaban, so they inhibit inhibit the factor 10A pathway, and that inhibits all of this stuff. And these people are on apixaban for months, 3 to 6 months, depending on their history. Now we'll go on to infective. Not long to go. So we have infective, we've got cystic fibrosis, and then we've got lung cancer, and then we'll have the clinical cases. So we should be done around about 8:40, I want to say. Pneumonia is a acute lower respiratory tract infection. Loads of different types. The most common type of pneumonia is community-acquired pneumonia. You can also get it if you have prolonged stays in the hospital, so that's what we call it, hospital-acquired pneumonia. If you've been on a ventilator for ages, you can get specific pathogens from the ventilator equipment. It's called ventilator pneumonia. Atypical is pneumonia caused by bugs that we wouldn't normally expect to cause pneumonia. So something like pneumococcal pneumonia, we wouldn't expect that. Then aspiration pneumonia is when someone has accidentally, aspired some food or liquid or some other substance into their lungs that's got bacteria in it, or it's irritated the breathing network, and then that leads to the development of pneumonia. I'm going to focus on community-acquired because it's the most common. The two most common causes of community-acquired pneumonia are strep pneumonia and Haemophilus influenza. So it's an infection of the lungs. You're going to get fever because it's an infection, that immune response. And because you have an immune response inside the airways, you're going to get loads of sputum production, and then that sputum is going to sit there and irritate the lungs, so you're going to cough it up because you need to get rid of it. All the phlegm, it traps the bacteria, and then your body clears it, and that's why you get a cough, is to clear that bacteria-ridden sputum. So you get a cough, which is productive of green sputum. You get fever, which can become rigors, which is really intense shaking if you get severe pneumonia. You cough and cough long enough, you're going to start busting capillaries and blood vessels, and that's going to cause hemoptysis. So you're coughing up blood. And then because you're coughing so much and because your airways are narrowed with sputum, you get short of breath. And if you keep coughing long enough, anyone who's had a really bad chest infection will know if you keep coughing long enough, you're going to start getting really bad chest pain. Again, the signs that we can look for: someone's using accessory muscles, labored breathing. And then in terms of the resp exam, you get dull percussion, increased vocal resonance. Increased vocal resonance because all of that sputum and pus and all of that nasty stuff is going to better conduct the sound. So because the sound of their voice is conducted better through that sort of semi-solid rather than it would be through air, we can hear an increased vocal resonance. Then delta percussion, because as we percuss, the sound waves are absorbed more by all of that gunk inside, so less sound comes back. And so that's what it would look like. All of this fluid in here in the alveolar spaces. Investigations, we can do oxygen levels. We can take the sputum that they cough up, we can send it for microscopy, and that lets us work out exactly what bug is causing the pneumonia and exactly what antibiotics they would respond to. So they cough up, let's say they cough up, Moraxella catarrhalis, and then it responds to a specific antibiotic because we put the antibiotic on the Petri dish and it kills the Moraxella. Then we can give the patient that antibiotic. So we can use it for culture and then sensitivities. Chest X-ray, which will look something like this. So you can see here is the region of pneumonia. Here you can see this opacification. That's where all the fluid is accumulated, because fluid is white on an X-ray and air is black. So because it's all accumulated, all that pus and inflammation, we can see it. Then we calculate a CURB-65 score, which is just a pneumonia severity scale. It's got C for confusion, U for urea, R for respirate, B for blood pressure, and if they're over 65, you get a point for each. And then depending on how many points you get, determines the severity of your pneumonia and how long you need to be admitted for and what kind of management you need. Okay. And that management is, if they have low oxygen sats, give them oxygen, and then most of the time, if it's bad pneumonia, give them antibiotics according to local guidance. I'm from Leicester, so what we do in Leicester is, depending on the type of pneumonia, you can give them Comox. If it's atypical, you can give them doxy. We give a lot of clarithromycin as well. But obviously, it's going to vary depending on where you are because of the different levels of antibiotic resistance in different locations. So pneumonia done. Now let's go on to cystic fibrosis, which is the main respiratory genetic condition. So cystic fibrosis is an autosomal recessive mutation of CFTR. CFTR protein is vital in the transport of chloride ions. And because chloride is an osmotically active ion, where chloride goes, water follows. So the pathophysiology is if you can't export enough chloride ions in your secretions, less water is going to follow it. So your secretions become thicker and they get stuck everywhere. Which is what makes cystic fibrosis such a nasty disease, because anywhere you have secretions, the secretions become thicker and they get stuck. So it can affect any part of the body which has secretions, which need CFTR proteins. And just to make matters worse, CFTR proteins regulate sodium channels, and they also excrete bicarb. So a lot of osmotically active ions being related to CFTR proteins. So you can see if that's mutated or abnormal, you can have a lot of problems with actually getting secretions to the correct thickness. And it presents as meconium ileus, which is meconium is the first bowel movement which is passed by a newborn, and if they can't make that bowel movement the right consistency, it becomes really thick and sticky, and it becomes so thick and sticky that it obstructs the bowel, leading to an ileus, which is absence of peristalsis. So you get this bowel obstruction. It can also present as malabsorption. You're feeding this baby and they're just not putting on weight. They're losing loads of weight because the pancreatic enzymes that you need to digest all of the food input don't work properly. They get stuck in the pancreatic ducts because they're sticky, because there's not enough water in them because of the CFTR mutation. And then you can get recurrent chest infections. Why? Because mucus produced is too thick and sticky, so it will get stuck. And it leads to disruption of mucociliary function, and you get all of this retained mucus with loads of bacteria, which is just breeding grounds for respiratory infections. But most commonly, it's detected on the newborn screening test. So we do blood tests and loads of other things, and we can detect cystic fibrosis mutations because we scan for it actively. And this is what I mean. All of these places have secretory functions as part of their normal physiology. And cystic fibrosis can affect one of them. If you're really unlucky, I guess all of them. But this is how it can present. So I just learned the main kind of presentations, these newborn ones. And then we had an exam question, someone who had pancreatitis and cystic fibrosis, and we had to work out what was going on because of the sticky, the blocked pancreatic ducts. I'm not going to dwell on this because look how much stuff, you've got pretty much all body systems involved here. This is how debilitating cystic fibrosis can be. You can also do a chloride sweat test. So if any concentration of chloride above 60 millimoles per liter in the sweat test is pointing towards a diagnosis of cystic fibrosis, you can do gene studies as well. Management, there's not a lot we can do apart from supportive, unfortunately. So no smoking, obviously, because this a person with cystic fibrosis is massively predisposed to, lung problems anyway. Adding smoking into that list of contributing factors is really not going to help them. Because they are so infection prone, you're advised to avoid other cystic fibrosis patients because they can pass infections between each other. If you put two high-risk patients in the same room, they might, cross-contaminate each other. And then avoid jacuzzis. It might seem like a strange one at first, but Pseudomonas, the Pseudomonas species love to colonize jacuzzis. And if a CF patient gets Pseudomonas, it's very bad because Pseudomonas pneumonia is quite nasty. And then same as our COPD patients, because they're high risk for infections, we give them vaccinations. So annual influenza ones and also pneumococcal protection. And there's loads of studies to show that nutritional optimization can really help cystic fibrosis symptoms. So focus on that. Then chest physiotherapy, which is this. So what this kid is having is that vest which he is wearing, it oscillates really quickly at a high frequency, and it helps to dislodge that sticky mucus. It assists the lungs to clear the mucus out. So it shakes really quickly, kind of breaks that mucus down a little bit and helps the kid to cough it up easier, which helps them breathe easier. But they have to go to this physiotherapy, very regularly. Then saline nebs as well, just to help try and break things down a little bit more. So on to lung cancer next. No, we're going over things very quickly, but you can always watch the recording or look at the slides and feel free to revisit all of this stuff. So lung cancer, the leading cause of cancer-related death in the world and the UK as well, which is why it's so important to know about. As many of the respiratory conditions, you can see the common theme today, most are caused by or related to in some way to smoking. 72% of lung cancer is caused by smoking as well. But you can also have genetic predisposition, so you can be at higher risk if there's a strong family history of lung cancer or just cancer in general. And then if you have had industrial exposure to things like asbestos, less common in the developing world, in the developed world. So places like UK, you're less likely to have asbestos exposure because we're much more aware of it and its dangers now. But there's some buildings on Leicester campus which have asbestos in the walls. But that's fine because asbestos only becomes a problem when the fibers are disrupted and they're allowed to become airborne. So if it's all locked in a wall, it's fine. But once you start breaking that apart and the asbestos particles become airborne and then people breathe them in, that's when it becomes carcinogenic. So loads of different types of lung cancer. The main ones are summarized here. So you can have small cell lung cancer, and then you can have non-small cell lung cancer, which is divided into the subgroups of squamous cell, adenocarcinoma, large cell, and carcinoid. And how you work out which one it is histologically. So these are all histological terms. We look at it under a microscope and the kind of cell architecture we see in the symptoms the patient has. We make a diagnosis of one of them. These are your typical symptoms of lung cancer. The main predominant symptom is cough, but important to note, closely followed by hemoptysis. So if someone is coughing up blood with a smoking history, lung cancer is going to be right up there on your differential list, especially if they're losing weight, because cancer is incredibly metabolically active. It likes to suck up all of the surrounding nutrients, which means less nutrients for the patient, so they start losing weight. Less energy for the patient, explains why they become so lethargic and tired. The scary ones are where lung cancer grows to, stage 2, stage 3, and the patient has no symptoms. And often they present too late for any curative treatment. So they can be asymptomatic, but most patients have some kind of cough or weight loss. The signs we can see are pallor because of anemia, because of that, the metabolic load of the tumor. They become cachectic, which is this. This is the exact same image they used in my year 3 OSCE. So this really emaciated, almost looks malnourished appearance because the cancer is eating up all of the energy. And then you have these funky things called paraneoplastic syndromes. So depending on what cancer you have, so the more poorly differentiated it becomes, it just starts growing random cells and they start doing random things. And sometimes they can start secreting hormones. So if you get really poorly differentiated cancers in small cells and they develop the cells which produce ADH, you start getting loads of ADH being produced randomly. And then that causes symptom of inappropriate ADH, leading to hyponatremia. And all the symptoms you get with hyponatremia, you'll get with the patient. And let's say the cells, mutate and turn into the ones that produce ACTH. So you get loads of ectopic ACTH production. Patient's going to have, cough, shortness of breath, weight loss, and also Cushing syndrome features, even though they don't actually have Cushing's. But it's because of this paraneoplastic. And then squamous cells can differentiate and start producing parathyroid hormone-related peptide, which is a protein almost identical to parathyroid hormone, not the same, but almost the same. So it starts pumping out loads of parathyroid hormone-related peptide, goes around the body and has the same effects as parathyroid hormone. You're going to get hypercalcemia and all of its associated symptoms. So the patient's going to come in with cough, hemoptysis, and all the symptoms of hypercalcemia. So you can see how suddenly these presentations can become, quite complicated if you have a paraneoplastic syndrome going on. How do we investigate for it? We do chest X-ray first, looking for things like this. Now, it's important to note, sometimes tumors can grow very little side to side. So we're looking AP or PA, so they can grow very little that way, but they can grow a lot forward to back. And those are the cases where you get a chest X-ray of someone with a massive tumor and the chest X-ray is clear. Because width-wise, the tumor is very small, but length-wise, it's just grown. It just happened to grow really long, so it's hidden on chest X-ray. Which is why, if you're suspecting lung cancer and you do an AP and it's clear, you do a lateral as well, and then you see this massive tumor. We can also do a chest CT for staging purposes, and then we do a PET CT scan looking for distant bone metastasis or metastasis to other organs. So that's what a CT looks like. You've got that's the tumor there. On the subject of METs, lung cancer can commonly metastasize to the brain, adrenal glands, bones, and liver. We'll pick that stuff up on a PET scan. Then we can stick a needle in, or we can, go through bronchoscopy and stick a needle into the tumor and take a sample of cells, which we can analyze under a microscope to work out what kind of cancer it is, and also stage it, TNM staging, which gives us an idea of the severity. And then treatment for lung cancer, we can cut it out. So we can do surgery and add chemotherapy to it, but that's only for kind of grade 1, grade 2 cancers. The more severe and metastatic the cancer becomes, the less we can do. That's when we have to go towards chemotherapy, radiotherapy. And for the stage 4 cancers and, the really distant spread METs and things, you have to palliate them, which is why lung cancer has such a high mortality. Okay, done with all of the content. Now we're going to go on to the cases. So we've got 8 cases. 7 of them are single best answers, and the very last one is something we do, and that's called SAQ, so single answer question. So that's instead of multiple choice, you actually have to write the answers out. So this is case number 1. I'll give you guys let's say a minute, because it's already it's already 8:30, so let's try and get through this quick. I'll give you a minute and just have a think about this. Make a note of your answer, mentally or on a paper, and then I'll go through it afterwards. So you've got a mom walking into a room. She finds her 4-year-old son struggling to breathe in his stridor, which is a high-pitched breathing. And then on the ground, the stem specifically mentions small magnetic balls. So it's specifically mentioning that it's not too far-fetched to assume that a small child struggling to breathe with loads of small asphyxiable objects on the ground is probably choking. So this is alluding to the very first clinical point I made.
I think you're muted there.
Yeah. How much did you hear?
Just while you were explaining, I think.
Oh, that's really weird. Okay, so because things are more likely to end up on the right side than the left, and then the second bit of information you need is because metal is going to show up as opaque on an X-ray. It's going to be that bright white. Because of that, the correct answer is radio opaque object in the right bronchus. You might see a clear chest X-ray, or you might see hyperlucent lung field if that lung has collapsed because there's no air entry in or out. But the most likely answer, the thing with all of these questions is the most likely answer, the single best answer. So even if other answers are correct, you have to choose the one which is the best fitting with the picture. That's E. Case number 2, a 17-year-old girl is having an asthma attack and she is using her accessory muscles of respiration. Which of the following is a muscle used during normal respiration? So this is a kind of question. It's one of those question styles where the stem is, sort of relevant, but then the question they're asking is completely the opposite to what it's on about in the stem. That's why it's always important to read the actual question which they're asking. So I can go through this one quickly because it's just a factual recall. So we got asthma attack. She's using muscles of respiration, but the question is asking which is used normally, which of the muscles is used normally. And scalene, sternocleidomastoid, pec major, and rectus abdominis are all accessory muscles. The only one which is a normally used muscle of inspiration is the intercondylar intercostals. We stick with the 17-year-old girl. She's using her accessory muscles of respiration, and so you encourage her to use her salbutamol reliever inhaler. Which receptor does the drug bind to in order to cause smooth muscle relaxation? Again, this is just another factual one. A lot of preclinical questions are like this, where you just have to kind of know the answer. We've got another part to this question where you have to know whether it's an agonist or an antagonist. Important to know because there is a massively important and commonly prescribed class of drugs, which the mechanism is it blocks beta receptors. So yeah, antagonizes them. So it's important to know the difference. Salbutamol is a beta-2 agonist, so it binds to the receptor and activates it, causing relaxation. The class which antagonizes it, of course, is beta blockers, which is why we can't give beta blockers. It's why we can't give non-cardioselective beta blockers to patients with asthma, because it will just bind to their beta receptors, induce smooth muscle contraction, and perpetuate an asthma attack. You can see in our all of this physiology helps you with your understanding. Right. So we've got a 74-year-old man coming to ED with hemoptysis, shortness of breath, and sharp chest pain. Where have we heard this triad before? So he has a BMI of 36, which is very high, and he smokes 25 cigarettes a day. The emergency team immediately begin conducting investigations to see what's going on. As part of those investigations, they do a VQ scan. So which of the following VQ ratios would be most expected given this patient's diagnosis? So you can see how we're moving slightly more from that early preclinical. We're starting to go half and half now with the physiology and the clinical. So you need to work out what this patient actually has, and then you need to work out what VQ ratio you'd expect with this patient. And working out what the patient has will come from the stem. So you've got one risk factor, which is the age. You've got the presenting triad, and you've got 2 more risk factors with the BMI and the cigarettes. Okay, so we've got an elderly gentleman with a very high BMI, which makes him predisposed to clots, and he smokes 25 a day, which means he's more likely to have a clot, and he's come in with the presenting triad of pulmonary embolism, hemoptysis, shortness of breath, and sharp chest pain. And pulmonary embolism because you're knocking out the bottom number of VQ ratios, so you're impacting the perfusion, but ventilation is relatively unharmed. You've got 4 liters or 5 liters, whatever, divided by a smaller number than usual, so VQ ratio is going to go up. And it's likely it's probably going to be even higher than 1.2. But remember, 0.8 is normal. 0.6 and 0.4 imply a ventilation problem, and 1 is something we'd physiologically expect during exercise. So the answer is 1.2. Case number 5, changing it up a little bit. Also, we're going to do a little bit of investigation interpretation now. So we're shifting more towards the end of second year level, kind of. We've got an 84-year-old woman with a 6-month history of poor exercise tolerance. She's got a productive cough and she's just generally fatigued, but she's had no weight loss. She's not coughed up any blood and she has no fever. She takes torvastatin and has asthma, for which she has salbutamol inhaler. She drinks 1 glass of wine per night, but she smoked 30 cigarettes a day for the last 40 years. So after looking at that stem and thinking about what the likely diagnosis would be, which of these investigation results would back up your most likely diagnosis? So again, 2-step process. You need to work out what the diagnosis is. Then you need to have a look at all of the investigation and see which one is most likely to fit with that picture. Even if you haven't done ABGs, you should still be able to work out what's going on with the ABG in this question, just using the reference ranges. Okay, let's go through it. So the stem, if you boil it down, is 84-year-old woman, 6-month history of poor exercise tolerance, a cough and fatigue, but no weight loss and hemoptysis. So it's probably not cancer. It could be, but it's probably not. And no fever, so it's probably not infectious. Takes torvastatin, so she's high cardiovascular risk, and she's got asthma. So it could be something related to asthma, but because it's been going on for 6 months, unlikely to be asthma. So it's likely to be something more chronic. Her alcohol history is insignificant, but she smoked 30 cigarettes a day for the last 40 years. What condition do we know which causes these symptoms with smoking history? It's COPD. And then looking at these, so now we have a diagnosis of COPD. We look at our investigations. This is a normal spirometry. It's a nice sharp curve, and then it plateaus at the top at 5 liters. So that's normal. And remember, I said restrictive lung diseases, which I haven't really talked about today, but it would be something like interstitial lung disease, interstitial fibrosis. It restricts how much the lungs can expand. So you get a squashed curve. But COPD is an obstructive lung disease because you're obstructing the flow of air through the actual bronchioles themselves. So you'd expect your obstructive lung defect to be something more like this, and then it takes much longer to come back. But this is restrictive, so it's not that. This X-ray, we have bilateral opacification, but aside from that, this chest X-ray looks relatively fine. You know, the diaphragm has a nice curve, and there's no other X-ray signs on here which would make me think COPD, especially when you compare it to this one, where you have a flat diaphragm. Remember the flat diaphragm from the chronic air trapping, and you have these massive lung fields. I mean, you can see they are huge. Over here, it's kind of, just to the bottom level of the heart, but here it's gone so down. You've got these massive lung fields, flat diaphragm. This is textbook COPD here. But if you want sure, you can eliminate these 3, and then you look at the ABG. All of the values are within the range, so it's normal. And we know that COPD presents with a compensated respiratory acidosis. So that's why the answer is D for that one. Case number 6, you got a 16-year-old boy born into resus after a road traffic accident. He's struggling to breathe and his trachea is deviated. And he is dropping O2 sats rapidly, and you've got signs of hemodynamic instability, a very fast respirate, very fast pulse. I think the diagnosis is obvious to everyone, but you'll need to remember what the exact management was. It's the exact case which I was talking about before, really, isn't it? So you've got someone with a road traffic accident, you've got a perforation into the thorax. You've interrupted that pleural seal and you've allowed air to go in, which has led to a pneumothorax. But there's so much air gone into that space that it's pushed the trachea to the other side, which now makes it life-threatening, warrants immediate management, and that management is a large bore cannula. So it's literally a really, a wide gauge thick needle, and we put that straight into the second intercostal space, and allow the air to come out through that valve system and let the lung reinflate, bringing that pressure off the trachea. Trachea bounces back to the middle. Patient can breathe a bit easier again. O2 sats go up by themselves, but we'd still give them oxygen as well. Cannula in the fifth intercostal space, that's wrong because that's where we'd put a chest drain. And chest drain goes in the fifth intercostal space, not the second. Salbutamol would do nothing here because this person is not having an asthma attack. And then again, chest drain goes in the fifth intercostal space. So chest drain in the fifth, cannula in the second, two different things. Okay, 7. So there's only, after this, there's only one more left, so we're nearly done. But Mr. Jones is an 80-year-old man living at home alone. His daughter brings him to the GP because she's really worried that he's been confused. So we're moving much more to the kind of end of second year clinical level cases now. He's much more confused than normal, but today in the appointment, he's comfortable. He knows where he is. He knows what time it is. And he just says, you know what, doc, I'm fine, but I've had this headache. It's not going away, but I've had it for 7 weeks. It's quite a bad headache, but it's not going away. So you look at his notes, and the only thing you see is a past history of stage 2 lung cancer, which was surgically operated on 14 months ago. And the surgeons documented, all the tumor was removed. It was a successful surgery. And he's had no symptoms of lung cancer since. So he's had no weight loss or hemoptysis, but he just feels a bit more under the weather. Which one is most likely? This question is pulling on a lot more than just respiratory knowledge. And you have a bit of a background knowledge of neurological conditions as well. Okay, so if we boil this case down, we've got an 80-year-old man who's becoming super confused acutely, with a background of stage 2 lung cancer, which was removed not so long ago. And because of that, he's high risk for metastasis, he's high risk for another tumor because he's had one in the past. And so because of that, the most likely answer is lung mets to the brain. Now, we can break this down in this format. So primary brain tumors, it's definitely a differential that you'd consider, but they're very rare compared to lung mets, especially in someone who's had lung cancer. Meningitis, this person does not have any mention of photophobia, no neck stiffness, no meningism. So we can safely say this person probably doesn't have meningitis. Stroke, there's no mention of unilateral weakness or unilateral sensory deficit. So it's probably not a stroke either. dehydration would not go on for 7 weeks. You know, he would have probably, if it was dehydrated this severely to become confused for 7 weeks, probably would have gone into AKI or something like that, which means that the most likely option is lung cancer next to the brain. It's a bit more of a difficult question. And then the last case is, so this is SAQ. This is not, you don't choose the most likely answer. You have to write the answers out. So this is testing your actual knowledge base. We've got a 66-year-old woman with a 2-week history of productive cough. It's getting worse over the 2 weeks, which is why she's come in today. She's got a fever. She has some pleuritic chest pain, but she's had no weight loss and she hasn't coughed any blood up. She knows where she is. She knows the day and time. And you do some baseline bloods and it comes back with a very high white cell count and a urea of 7.8. Her respiratory rate is 31 and her blood pressure is 94/63. She's had no hospital admissions and she's not immunocompromised. Question 1, calculate a CURB-65 score. Now, because I'm not sure how many of you have committed this to memory, I'm going to give it to you, but just learn this score because for us anyway, it's one of the ones that they can ask us to just work out off the top of our heads. But I've given it here so you can just kind of read across. And then from that, you can infer whether she needs hospital admission or not. Question 3, describe the most likely finding on a gram stain. So that's going back to, again, what is the most common cause of this condition? And what does that organism look like on a gram stain? How would you treat her briefly? And then based on the drug that you've chosen, how does it work? So this is more in keeping with the kind of clinical questions that we get asked. So it gives you a clinical STEM, asks you to do some basic clinical stuff, and then asks you a few things about physiology and pharmacology and things like that. I'll give you a little bit longer on this one because there are 5 questions. So we'll go until, let's say 8:50. We'll go until 8:50 and then I'll show you the answers and then we're done after that. So 1 minute left, guys. Just some clues. So we're thinking about pneumonia here. If you were confused about the diagnosis because you've got productive cough, pyrexial, and then massive clue is they've given, well, I've given you all of the different parts of the CURB-65 score, which points towards pneumonia. So calculating the CURB-65, even if you've never done it, should be pretty straightforward because you just match up all of the points. So is there any note that she's confused? Let's see. Doesn't mention anything. So there we go. She's orientated to date, time, and place, so she's not confused. So she doesn't get any points for that. Urea is 7.8. She gets 1 point. Her respirate is 31, which is above 30, so she gets 1 point for that. Blood pressure, her systolic is above 90 and her diastolic is above 60, so no points there. She's 66, so she gets a point for her age, so her carb score is 3. And if you guys remember back to the extended picture of this, I didn't give the extended picture on purpose because it would make it too easy otherwise, but a carb score of 3 or more is 100% hospital admission. If you have a carb score of 1, most of the time you can be managed in the community. If you have a carb score of 2, it's at the discretion of the medical practitioner whether they should discharge or whether they should admit. So that's the kind of gray zone. So that's where you're looking at kind of, if you have a carb score of 2, but this patient's immunocompromised, you're going to admit them. But if it's a carb score of 2 in, a 23-year-old healthy university student with no medical background, you can manage them in the community. If they have a carb score of 3 or above, you always admit. And if it's a carb score of 5, you're looking at kind of more intensive admission. And then the gram stain. So the gram stain, yeah, so carb 65, you got those 3 points. She needs hospital admission. And then the gram stain, the most likely cause of community-acquired pneumonia. So again, there's different types of pneumonia. There's no mention in the history that she's been in hospital. There's no mention of ventilators, that she's immunocompromised or anything like that. So you can say that this is community-acquired pneumonia. Most common cause of community-acquired pneumonia is strep pneumonia, which is a gram-positive cocci in chains. So strep is gram-positive, streptococcus. So that's where the cocci comes from. And then one of my friends told me a really useful trick to remembering the difference between how Staphylococcus and Streptococcus is arranged on a gram stain. So Staphylococcus, this is their way of remembering it. Okay, so Staphylococcus, staff, as in staff in a shop, and if you think of staff in a store, they all clump together and they're all talking and they're huddling, especially in shops like in certain shops like JD Sports, they're all huddled together and talking. So that's the way that we all remember it. Staphylococcus, staff grouped together, and the bacteria on the Staphylococcus stain are grouped together. And then you've got streptococcus, which is not staph. So that's the one which is in a line. So it's in chains. That's just the way that we remember it. But whatever works for you. And gram positive versus negative, you just have to, that's just rote learning with that one, unfortunately. So appropriate treatment, it's fair enough if you just say antibiotics according to local guidelines, because not everyone here is a Leicester student, so it's gonna vary. But if your thought process was give her antibiotics based on what we do in our trust, then that's fine. But if you put co-amoxicillary through, then that's okay as well. Then mechanism of your chosen drug. I didn't fill in an answer here because there's so many different antibiotics. So you're gonna have to double check yourselves whether the antibiotic you listed lines up with the mechanism of action that you chose. But I know it's been a long session. And we've covered a lot of things. We've covered all the main important points of respiratory physiology. We've covered all the base anatomy, which in itself, that's like 12, 13 lectures. And then we've gone over all the common conditions, which is another whole term of respiratory lectures. And then we've done exam questions as well. So I'm sure you guys are all super tired, but we'd really appreciate it if you could just fill in the feedback. And if you have any questions for me, feel free to drop them in the box, or if you want to email me about anything that we've talked about today, I've put my student email up there. Yeah, thank you very much for listening.
Thank you so much. That was such a great and comprehensive talk. You went over so many things that I think are so important in respiratory. So thank you so much for doing this. And yes, guys, so please do fill out the feedback form. It is very helpful for all of us, really, but a lot of effort has gone into putting this presentation together, and some spent about 2 hours trying to give this talk to you, so please do fill that form out, and keep an eye out for some more sessions. We'll try to get some more done once we start back in January. And like we said, if you have any questions, do send them our way. And just sort of UKMSA related headlines. So we are doing some recruiting, and we have a few opportunities coming up. I can put a few links in the chat if you'd be interested. But thank you so much for showing up. And if there are any questions, please do send them our way.
Yeah, and if you're watching on the recording, I'm happy to answer questions if you're emailing me from that as well. You know, if you're watching this in the future. So yeah, thanks everyone for coming. I know it's a lot of commitment to put in on a Tuesday evening. Cheers.